Right, thank you, Kathy, and thank you, the Macular Disease Society, and indeed all yourselves for coming along. So hopefully I can give you some useful information. Obviously, I've been asked to talk about research, and what you really all want to know is, can we cure you? I'm afraid I can't promise you that. What I can do, however, is try and give you an overview of some aspects of the research that is going on. I started as a consultant in 2000, so it's now 15 years ago, in April, so almost exactly 15 years ago. That was having done a year's fellowship in Moorfields in London. At that time, for a year, probably lasered about 3 patients with macular degeneration. We basically didn't treat anybody. There was no effective treatment. We talked a lot about eating yellow vegetables, but that was about as good as it got, I'm afraid. So we understood a lot about macular degeneration, but we had no treatment. About a year after starting in Newcastle, PDT came along, and that's this, some of you may have had that, I'm not sure, but photodynamic therapy, a form of targeted laser that did less damage to the eye and hopefully treated the blood vessels that Simon's been talking about. That would help a percentage of people with macular degeneration, but by no means everybody. And vision still was lost, but the process was slowed. It helped to some extent. 2006, we had Avastin started to become available. 2007, Lucentis. 2013, I think it is, Eylea, or aflibercept. Those 3 medicines all effectively do the same thing, which is block vascular endothelial growth factor. That is a medicine that is a substance produced in the eye that causes blood vessels to leak or bleed and grow. And it's basically an antibody that blocks that, so it stops it leaking and bleeding, stops it growing. And if that is your main problem with the eye, it's really a very good treatment. So I've got several people now with at least 10 years of follow-up who started with a bit of PDT, have had lots of injections, up to 50 injections, I'm afraid, if you haven't reached that level yet, but a lot of injections, and are maintaining some useful vision. That's not to say they see perfectly. Macular degeneration is not just about VEGF or blood vessels growing. It's also, unfortunately, atrophy, thinning of the tissue, scarring. That's all part of the process. So our current injections help one aspect of it. So in terms of prevention, well, as was asked, sadly, no, we don't have any prevention in that the main 50% of your risk is genetic. The next biggest risk is basically getting older. The longer you live, you're more likely to get macular degeneration. There are environmental things, diet, smoking, blood pressure, sunlight, that have a part of it, but nearly every patient I see says they have a healthy diet, eat lots of vegetables, and don't smoke. So, what can you do? The reality is you can't prevent it. As Simon has said, the most important thing, and unfortunately probably I'm speaking to the wrong audience, but maybe if your family, the most important thing is if you did develop wet macular degeneration is to get treatment early. We know from all our audits and looking at the outcome of all this treatment, if you start with good vision, you're much more likely to keep good vision, certainly for some time. That isn't indefinitely, but we can maintain vision much better than we used to. In the majority of people, not everybody, depends how the condition presents. In terms of, there was talk about this short-sightedness, android streaks, macular degeneration, and indeed diabetic retinopathy. They're all treated with anti-VEGF injections if the problem is a blood vessel growing and a blood vessel leaking, because that's the biology of it. The levels of VEGF go up, and it induces these problems. You block it, and it goes down temporarily, and that's the problem. We hope the eye heals itself, and you don't keep needing injections. And there are some people who actually we stop injecting, and a year goes by, and the vision's still reasonably good, and they haven't needed it anymore. But it doesn't happen that often. In our audit of 4 years worth, our first 4 years of using Lucentis, about 10% of people reached that stage and were discharged with relatively good vision. The majority keep having treatment. The other reason when we stop treatment is effectively you have a central scar. It has no longer got any fluid, no longer got any bleeding, there's scarring. Often associated with poor central vision, but it varies how poor that is. It's all very well me saying this. If it's your eyes, whatever it is, it's bad. Relatively to not having had treatment before, which is what I was used to, as I said, back in 1999, the vision was an awful lot worse. So we have very few people who were as bad as before we started treatment. That isn't a great deal of comfort if you find, well, either way, I can't read. But the eyes do look a lot better than they used to. But the problem is you've got to keep coming every month, treated, not treated, it goes on and on. So yes, ideally we want to prevent the whole thing in the first place. People have tried doing laser to the retina to get rid of drusen, which are little deposits. That's a very early stage. There was the laser for drusen trial. Unfortunately, in that there was actually a higher instance of developing blood vessels, so that trial was stopped. There's still research going on into that using nanometer length lasers, very short and very fast laser pulses that theoretically might be much more targeted in the eye and cause drusen to regress and might reduce the progression of wet macular degeneration. But that's yet to be proven, but that research is ongoing at the moment. I think the current research, so what can you expect in the next 3 or 4 years in terms of any new treatment, we're still really talking about trying to prevent or treat wet macular degeneration and stop it getting as bad as it might. Trying to give treatment that will last longer so you don't have to come so often to the clinic, you don't have to have so many injections. So in our department in Newcastle, we're going to be starting 2 trials this year, which are phase 3 trials. So I'm sure from your side of things, it is very frustrating how long it takes for anything to be developed. But essentially, you have to do you have to do a lot of basic science. You have to understand what is the biology of macular degeneration. Is there a target we could actually treat? Is there some drug you can develop that might alter that pathway? Then you need to do a phase 1 trial, or animal studies probably to start with. Is it safe? Can we actually give it to people? Can you then do a phase 1 trial to show that it might work at all? And it's safe. Then you do a phase 2 trial, which is really trying to show in principle, does it work? And then if that does, you then may be able to go on to do a phase 3 trial. That all takes quite a long time. Phase 3 trials are very expensive. We're talking millions of pounds and a lot of years of work to prove that it is safe and actually does work. A lot of people say, well, can't you just give me the treatment? I'm prepared to take that risk. The problem is you wouldn't thank them if it went wrong and you had a terrible side effect. And also, actually, unless you do a proper randomized trial, you don't know if the stuff works. You've all heard of the placebo effect. You can do anything to somebody and they'll probably feel a bit better if you sell it or explain it in the right way. That doesn't mean it works. So you need to do a proper randomized trial to be sure what we're doing actually works. So in terms of new trials this year, there's one on something called abicipar-pegol, or also known as DARPin, which sounds a little bit easier to me. DARPin, that's sponsored by Allergan. They did a phase 2 trial of 64 patients, given 1 milligram of this, 2 milligrams, and compared it to a third group of patients giving Lucentis. And all the patients got an injection I'm afraid it's still injections, injection at baseline, 4 weeks, 8 weeks. And then the Lucentis patients continued to get monthly injections to 16 weeks, whereas the DARPin ones didn't. And the final outcome was at 20 weeks, so 12 weeks after the last injection. And actually the visions, one way of reporting outcomes is mean number of letters improved. So you're aware of reading the vision on these charts. We record the number of letters you can see. But basically at 20 weeks, with the higher dose of the DARPin, got a mean gain of 9, with the lower dose 7, and with Lucentis 4. So it is better, and it seemed to last 12 weeks on a small sample. So that's 64 patients, about 20 in each arm. So it's quite encouraging that it does last longer, and it actually seems to work better. It actually is still something that's blocking VEGF. So it's still targeting the same bit of biology, it's just doing it in a different way. It'll take probably a couple of years before we can do the phase 2 trial and actually know that it works. because it'll start this year. The recruitment will take a few months. This will be for new people who've just getting macular degeneration. So as I said, we're talking about trying to treat it as it starts and trying to stop it getting worse and get a better way of doing it. There's another treatment called platelet-derived growth factor, or one of the trade names is Fovista. That's currently with Novartis and another company called Ophthalmologist. Basically, it's another growth factor. So whilst VEGF, the current drugs all work against, is a very important factor, there are other ones. So platelet-derived growth factor, that, again, all these things are actually needed for the way your eye works, so we don't want to completely get rid of them. They're part of the balance of the eye. The problem is in disease, you get too much of one. What happens with the VEGF treatment is, or what happens with the blood vessels is they grow and they start to leak, but actually they get these parasites, they get things growing around them that begin to stop the Lucentis actually properly targeting the blood vessels. So you stop the leak, but you can't get rid of the underlying blood vessels. So some of you may well be aware of if you're diagnosed with wet macular degeneration, you may have a fluorescein where we inject some dye and we look at the actual pattern of the blood vessels. If you have a year's worth of Lucentis and repeat the fluorescein at a year, you'll probably find the blood vessels are still there. They're less leaky, but they haven't gone away. And that's one of the reasons you just have to keep injecting it. It's also one of the reasons why some people need a lot of treatment and some people need less, because it depends how protected this blood vessel network is. The stuff grows around it, and you can't get the treatment into exactly where you want it. The platelet-derived growth factor actually strips off the parasites from these blood vessels, so the medicine can get in better, and it actually causes these new blood vessels to shrink and actually disappear, as opposed to just stopping them leaking. Unfortunately, the current trial plan is to do 2 injections once a month. So I'm sorry about that, but you basically get your Lucentis or anti-VEGF injection plus this new one. And again, they've got to the phase 2 trial. They've done a phase 2 trial. And the comparing, and that was a much bigger phase 2 trial, 449 patients, so we're much more confident that it genuinely does work. And again, it was compared to Lucentis, which is often the sort of gold standard comparison. And the group that got the double treatment did better. They got an average letter gain of 10.6 as opposed to 6.5 in this trial. So it seemed to work better. But the very encouraging thing was the blood vessels disappeared. They didn't just stop leaking, they disappeared. And also you seem to get less scarring. Because the problem with this macular degeneration, yes, it's the leaking, but actually we can control that pretty well with Lucentis. The problem is you also get scarring. So you stop the leak, but the eye still has to heal somehow, so you end up with some fibrosis, which is the scarring. And this medicine seems to reduce that. So it does look quite encouraging. Bayer is also developing a similar platelet-derived growth factor, but they hope to mix it in the same vial as their anti-VEGF, so it would only be 1 injection. But they appear to be about a year behind in terms of the research. So Fovista trial, there's one already started with a company called Ophthalmologist. Novartis is starting their trial this year. It'll again be another couple of years before it actually proven to work, probably another year. All these things are going to take 3 or 4 years at the earliest to actually finish the trial, get licensed, maybe even another year, then actually be funded. So it takes time. But they both look to be fairly promising new treatments that will complement what we already do. Another aspect of all this is dry macular degeneration, and all our treatment currently is targeted at stopping blood vessels growing, stopping them leaking. But actually, a lot of the problem in macular degeneration is dry, so you're just the back of the eye is just wearing out. And it isn't true to say you either have dry or you have wet. Nearly everybody who's got wet macula has some dry macula to it. Some people just never get the wet part, it just becomes atrophic. So it's a bit of a balance how much of what you have. But the understanding of why we're getting macular degeneration is 50% of the risk is genetic. And that has been shown, and there's quite a few genes that have been found, and a big group of those are complement, which is actually part of your normal immune system. So it helps you fight infection, But if complement systems go wrong, they can cause some of these autoimmune conditions. And therefore, it does look like macular degeneration, whilst it's purely one tiny little bit of the back of the eye, is probably actually a systemic disease in that it's due to imbalance of the complement, which is everywhere, not just in the eye. But anyway, having found this, it is therefore possible to think about, can you alter the amount of complement expression in the eye that might alter the way the disease progresses. So it's quite complicated, and I have to say I don't fully understand it, but there's a lot of types of complement. There's different targets that could be treated. There have been one or two trials already that haven't shown promise, but there is one which blocks something called factor D, and the medicine, again, is difficult to pronounce, lampalizumab. I don't know what the easier name for that is. Lampalizumab, I think it is called. But basically, it is another treatment. It's from Roche this time. And they're targeting it for geographic atrophy. So this is not treating wet macular degeneration. It's not just treating, it's only treating one type of dry macular degeneration, which is a specific pattern called geographic atrophy, which is where you have a patch of thinning and that gradually grows. Quite often that can sort of develop around the center. So actually the center vision is quite good, but you begin to find you can't read because you lose things to the right or the left of the center, because you've got this thinning around the middle and it gradually progresses into the center and makes the central vision not good. Phase 2 trials have already been done, and they did seem to show a slowing down of the progression of geographic atrophy. But interestingly, there was a question about genetic testing. Currently, there is a lot of stuff known about the genes. The problem is that it's complicated. You can have raised and lowered levels of different complement, and we don't truly know if you have a particular measure, does that mean you're definitely going to get macular degeneration, or just probably? It's a matter of risk. And also, even if you knew you had a slightly higher risk based on your complement genes, we can't do anything to stop you getting it. So it becomes a bit questionable whether you want to know. But it is possible to buy commercial tests for your complement levels and have a risk profile done of whether you're more or less likely to get macular degeneration. I don't know if that's advisable, but it is possible. And for this study, however, they looked at the genetics of the complement genes and discovered that if you had a particular mutation in complement factor 1, and the treatment was much more effective. So in this group, there was a 20% reduction in progression of geographic atrophy. But if you had that particular genetic change, it was a 50% reduction in progression. So we're going to be involved in a trial of using this medicine, again starting this year, for this subset of people with geographic atrophy to see if it slows down. But we'll also be testing the gene to see, is it true that if you have that gene, it works better? So if that's true, it's beginning this idea, you may have heard of it, the idea of personalized medicine. In other words, currently, for most diseases, everybody gets the same drug. But actually, we're all different. And maybe some drugs work better in some people than others. So if you knew why, and often that is to do with a gene, you may be able to say, well, this medicine's better for you and this one's better for you. We shouldn't all necessarily have the same thing. So this is one of the first conditions in the eye where that may prove to be true. So these treatments are all talking about, or these studies are all trying to prevent the problem in a sense. You've already got wet macular degeneration, can we give you a better treatment? Or you've got dry macular degeneration, can we stop it getting worse? We're not talking about repairing the eye. So the thing I'm sure most of you want to know about, or at least I always get asked, is what about stem cells? What about gene therapy? You've probably heard about it for quite some time now, and it is developing. The bottom line is, though, it's very complicated. It's very difficult to produce a stem cell that does what you want. What you want is this scar to be taken away and a new bit put in and it all to work normally again. That is going to be some way off. But increasingly, the biology of how can you make a new eye? You know, you might think that's crazy, but actually somebody has grown an eye in a petri dish from stem cells. Not a human eye, but a sort of eye shape. It is possible, theoretically. So there's different approaches going on. The most well-known one is probably the London project of trying to grow retinal pigment epithelium. So the macula, you've got different layers. It's a bit like it's the wall of the eye just has several layers to it. On the inside, if you're looking from the inside of the eye at the macula, you've got the nerve fiber layer, then you have the photoreceptors, then you have the retinal pigment epithelium, which they all sit on, and then underneath that's the choroid, which is a big blood supply. So often the problem with macular degeneration is actually the retinal pigment epithelium, this layer that supports the photoreceptors. It's the photoreceptors that actually detect the light. If the retinal pigment epithelium starts to die, the photoreceptors then die, then the nerve fibers all die. And so the whole thing stops working. But theoretically, maybe the retinal pigment epithelium might be the first part of it to start going. So if you could repair that, maybe you can protect the overlying photoreceptors. So that is the sort of theory behind the idea of stem cells. Can you grow a retinal pigment epithelium and then put it in the eye to preserve or replace damaged retinal pigment epithelium and allow the photoreceptors to work better? And that is what they've been working at for a long time. We've been told there's going to be a trial coming up for a long time. Indeed, I have had at least one or two patients who've been to London to say they want to do it 5 years ago, and it's still not happened. But Lyndon de Cruz is one of the key people involved with this. Actually gave a talk in Newcastle yesterday and said that they're going to start the very first trial in 2 months' time. Having said that, don't get overexcited. What we're talking about is 10 patients where they managed to grow retinal pigment epithelium. They put it on a basement membrane, so you have to put it on a layer. You can do an operation where you lift the retina up and slide it underneath, theoretically. The problem is, in most people with macular degeneration, or at least if you know you've got macular degeneration, you've already got damage to the overlying photoreceptors. So I can't see this ever personally going to be a real cure. What they're looking at for the very first trial is people who have had a sudden change. So while most people with macular degeneration, it's a slow process, the dry changes develop, then you start getting distortion, then blood vessels grow, it builds up. You can get a sudden hemorrhage. So you've had a relatively healthy eye, sudden hemorrhage, or you have what's called a pigment epithelial detachment, which is a particular pattern in the eye, and suddenly it tears. So you've got what's called an RP rip. So suddenly that retinal pigment epithelium that was relatively healthy becomes very bad. So if you've had a very short time, then maybe the overlying photoreceptors still work. So you might be able to operate and replace that retinal pigment epithelium. So that is the group of patients they're looking at. People with a sudden change from healthy eye to unhealthy eye. If you quickly replace the retinal pigment epithelium, will you get the photoreceptors working again? But at least it's a start. We've been waiting for this trial for a long time, so it's starting. I'm still not clear in my own mind how that's really going to solve the problem, because it's only one of the layers. In Newcastle, we actually have the Centre for Life, which is a big genetic research laboratory. One of my colleagues, David Steele, has got very involved with stem cells as well, because there's actually a big stem cell research going on in Newcastle into lots of different things. For the eye, actually, we use stem cells for repairing the cornea. So it's actually one of the few actual clinical uses of stem cells are in the eye for the cornea, so the front part of the eye. Anyway, in the laboratory, we're looking at can you grow photoreceptors and the retinal pigment epithelium. And I think long term, that's going to be a better option, because you're not just replacing one layer, you're replacing a whole sort of sandwich of the retina. If you can replace both the retinal pigment epithelium and the photoreceptors, well, we do have more of a potential chance of repairing the eye. So that is still very much in the development stage. Can you actually get the cells to turn into photoreceptors? Now, that can be done. You can grow layers of retinal pigment epithelium. You can grow photoreceptors. To get them all together, to get them reliably to do so, to actually put in an eye is a little bit of a way off, but it is developing. So that is one way of trying to repair the eye. The other, I guess, is gene therapy. So it does get all quite complicated, but gene therapy is another area where we try, but that's mostly relevant for people who have a specific genetic condition. So Stargardt's, I don't know if anybody has Stargardt's here, but Stargardt's, one or two people. Okay, Stargardt's is a known genetic cause of, I guess, what we call a juvenile macular dystrophy. In other words, it tends to occur at a younger age. But we do know the gene that causes that. We do know quite a lot of biology of that. And there actually has been a gene therapy trial just started. So we actually have got one patient in Newcastle who's been involved in the very first sort of study. I think there's only 3 people in the world who've had it, but anyway, they're starting getting gene therapy for Stargardt's. There's something called a form of retinitis pigmentosa, RP65, where that was the first one where some gene therapy was tried to either hopefully to reverse an aspect of retinitis pigmentosa. The early studies were quite encouraging in terms of giving some visual improvement. And there's another condition called choroideremia, again genetic, and there's a gene therapy trial going on for that. These are all quite rare conditions. Stargardt's is the more common of those 3 I've mentioned, but there is a known gene and therefore potential to try and modify it. I think we're very early days of whether these trials will really work, but the trials are starting, and we've talked about gene therapy again for years, but it is beginning to start. At least the trials are starting. The only other way is, well, can you just bypass this whole business and give you an artificial eye or a microchip in the eye? And you've probably seen that on the news. People have had microchips put in the retina, the little microarrays to detect light. I think they're basically, really, as my understanding, for macular degeneration, that's not going to be something you want. I think what you shouldn't forget is that nearly always, with macular degeneration, bad as it is, you lose the central vision, but you keep the peripheral vision in vast majority of cases. There are rare cases where all the vision can be lost, but that's very unusual. So normally it is poor central vision, but you do still see. Most of my patients will tell me, well, they can't see who I am. They know I'm sitting there, but they can't see my face. That's different to seeing nothing at all. And the people who've had those microchips, we're talking about people who see nothing at all to be able to do some vague navigation. So there has been a few people who have them. But the physics of microchips as such, it's unlikely you're going to get very high resolution imaging, and certainly not safe enough to put into somebody who actually still has some useful, albeit disappointing vision. To actually replace the centre and not damage the periphery is a big ask. There is another area of research, something called optogenetics, which again was in Newcastle, and in fact we had a talk on that 2 years ago on the first one of these. There is something called opsin in the eye, which is a light-sensitive detector that is not in your photoreceptors. And if you could make those cells more sensitive to light, maybe they could bypass the need for the photoreceptors. So there is a scientist in Newcastle working on trying to make the opsins in the eye more sensitive to light. Again, how practical in the end that will be, I don't know, but you get around to the physics problem of putting something artificial into the eye. You're actually using what's already there with a gene therapy approach to make your eye more sensitive to light. So I'm not sure what time we're on here. I think I've said a lot in terms of possible treatments. So as I said, just to sort of recap, we've got a long way to go. We can't prevent this condition. Our best results by far are detecting it early and treating it early. If your problem is wet macular degeneration, injections work well. I think in the next 2 or 3 years, or 3 or 4 years, we are going to have better injections that last longer. Repairing damage and replacing it is a lot further off, but we do understand it a lot better and have several different approaches that are speeding up in terms of their development. So thank you.
Lovely. Thank you very much indeed, James Cook.